Hello, everyone, and thank you for joining us for this exciting symposium on resilience during COVID-19. We have put together a group which can provide different perspectives on resilience during COVID. We're going to hear about data collected globally, especially in Europe, through an online crowdsourcing website from Professor Rafael Kalish. We're going to hear about similar study to an extent that was done primarily in the US and in Israel, which I will present. And we will then go and hear about more specific populations, like populations of healthcare providers and patients from Israel by Professor Doron Gotthelf. And lastly, we will hear a very unique perspective on a cohort that was ascertained in the University of Pennsylvania in Philadelphia by Raquel Gur on pregnant women during COVID. So I thank you for being with us, and I have the pleasure of presenting our first speaker for today, Professor Rafael Kalish from the Leibniz Institute of Resilience Research and from the Johannes Gutenberg University of Mainz from Germany. I welcome him, and I wish you all to have a nice time during our symposium.
Thank you very much, Ray, for the kind introduction and most of all for putting this symposium together. I also thank the organizers for allowing us to speak about resilience in the pandemic in this symposium. And I'm standing here for many colleagues from a range of institutes across Europe who are working together in the EU Horizon project Dynamo, which stands for Dynamic Modeling of Resilience. And I'm also representing dozens of colleagues from around the world who came together during this crisis, a kind of rapid response team volunteering in an effort to learn about how we can withstand Corona. So these are the authors, and they will surely forgive me if I don't name them each. This is my disclosure and my funding information. Now, we are talking about resilience to the Corona crisis, and that requires a brief consideration of what that is, resilience. There are long debates in the field about how you should define and how you should measure resilience. And you can read about that debate in this paper if you like. I will present the standpoint of this group of researchers and also of an international network, INTRESA, which has been founded with the objective to harmonize and improve resilience research. So our perspective has probably been gaining a bit of ground in the past years and in many ways has become at least one standard in the field. So the idea of that is that we understand resilience as the maintenance or also the quick recovery of mental health during and after periods of adversity. That is, you experience difficulties like a traumatic event or chronic challenges, perhaps physical illness. But despite of that, you do not develop a lasting stress-related disorder or stress-related dysfunctions. That means resilience here is an outcome. You can actually observe whether or not someone stays healthy. It is not any kind of predisposition or trait or personality characteristic in that perspective, although there may be such markers that predict to some extent whether someone is going to stay healthy despite adversity. We call them resilience factors. It is also not any specific process of adaptation or coping leading to the outcome. We call such processes resilience processes, and we are very interested in understanding them. But the point here is that the definition is atheoretical in the sense that we do not predefine which factors or processes determine the outcome. Reason being that we do not know them yet, at least there's still much room for discovery. Finally, if you adopt such an outcome perspective, then you ideally want to do longitudinal studies in which you examine factors and processes that shape that outcome. Now, this is what we are doing quite extensively in various ongoing longitudinal studies, including those shown here that all started or were about to start before, well, this, right? And given this, we wanted to get very quick information about potential resilience factors in the pandemic, because that kind of information is completely lacking. We do not know what keeps people going in this very peculiar kind of stressor situation that we all have now been in for some time. So in complete violation of what I just said about the importance of longitudinal studies in determining resilient outcomes, we immediately, during the first lockdown in Europe, started a cross-sectional online survey in which 16,000 participants from 24 language areas told us about their resilience and their resilience factors. Published the results of this immediately as preprints in April 2020 and made quite some efforts to disseminate this to the public via basically any kinds of channels. How did we measure resilience? We could not ask subjects, we could only ask subjects once in our survey. So we asked them to tell us how potential symptoms or problems of anxiety and depression in particular had been in the past 2 weeks, that is since roughly the start of the lockdown, relative to what they normally are for them. So at least retrospectively for those 2 weeks, we could perhaps see if participants thought they had been getting worse or perhaps stayed stable or perhaps also improved. So any of these trajectories is in theory possible. Now, if resilience is staying healthy despite adversity, then you need to measure the adversity that occurred, because otherwise all these changes here could be trivially explained by different levels of stress exposure. So this guy here or this guy here might have stayed all right simply because they got less hit than, for instance, this guy, or perhaps this guy even felt better because their life had actually become less stressful in the lockdown, which is also something that some of us have observed. Thus, we also asked our participants what they had been through in these past 2 weeks, using a list of 29 corona crisis-specific and a list of 11 general stresses. To give you an idea, people very often reported stressful media coverage, restrictions in their leisure or social activities, obviously, but the stresses rated as most severe were those less frequent events of not being able to attend the funeral of a loved one or to visit them at hospital. And in the general stressor list, people reported political events and social conflicts as the most frequent stresses and death of a loved one as the worst. You might wonder immediately if these were not actually also caused or at least exacerbated by the crisis. And indeed, the exposure scores we built for both lists were highly correlated. So we combined them into a common score that expressed level of adversity. Right, so here we are. We have this change information of mental health. We have stress exposure as good as it gets with only one survey time point. And we do see, and that is reassuring, that these are pretty well correlated, suggesting that more stresses means more mental health problems. The trend line here, the blue line, is the normal reactivity of people's mental health to stressor exposure in this sample. And that allows you to say that anybody here above the line had developed more than normal levels of symptoms given their stress exposure, whereas these guys here below the line are doing better than normal. They were less reactive than the norm. So the residuals to the norm line express individual stressor reactivity, controlling for level of exposure. And you can now call this guy here, for instance, or that guy acutely resilient, so acutely in our short observation time window, and maybe this one here or this one, just as examples, you could call them non-acutely or acutely non-resilient. And you can now take their regression residual or the inverse of that as a continuous measure of that differential reactivity, meaning as an approximation of their acute resilience to the stresses they've been experiencing in this recent lockdown phase. Now, you have a measure of resilience, but what makes them so, right? We also ask our participants about personal factors. We find that perceived social support, optimism, and self-efficacy are associated with high resilience scores, so the usual suspects kind of, which is first indication, I think, that resilience factors known from other types of adversity might also be effective in pandemics. As a kind of sanity check, we also see that if you find that you usually recover well from stress, then you're also more resilient in our measure. So it's a kind of nearly a self-perceived resilience, if you like. And another sanity check is that neuroticism is negatively associated. Now here we were specifically interested in people's appraisals. Positive appraisal means that you avoid evaluating potential threats in an inappropriately pessimistic, catastrophizing, or helpless fashion. That is, the construct of positive appraisal includes reasonable but not delusional degrees of optimism, non-catastrophizing, and self-efficacy, control, or coping potential. But it is a broader construct than any of those. And if you want to know more about that, you can read in this paper here. Now you can appraise threats positively in that sense in a kind of habitual style-like fashion. And positive appraisal style or tendency or bias, if you wish, is indeed highly significantly positively associated with resilience, controlling for any kinds of covariates. We also asked the participants about how they appraise specific threats. That is here the crisis. So there's specific appraisals, and that is also a very significant resilience factor, as you can see here. In accordance with our theory, positive appraisal style partly mediates the influence of perceived social support on the resilient outcome, which could be interpreted speculatively in a way that if you know you can generally trust in getting support from your social networks, family, friends, neighbors, whatever, in cases where you come into a situation, if you should come into a bad situation where you need support, then you also generally see threats or such kinds of situations as less threatening. You appraise them as less bad, and that makes you more resilient. And also in accordance with theory, the effect of a positive appraisal style on the resilient outcome is partly mediated by how well you think you usually recover from stresses, your perceived stress recovery, which, as I said already, is nearly something like self-perceived resilient functioning. So an interpretation here could be that you appraise threats in an adaptive way, and that keeps your stress reactions from overshooting and chronifying, which in turn helps your mental health. Now, if you ask what the strongest of all these resilience factors are, then it is this self-perceived resilience or stress recovery, REC, immediately followed by, well, not the appraisal style, but how you appraise the current crisis specifically, your specific appraisals. So that is in line with the crisis being the dominant stressor during this retrospective observation period, which was in the first lockdown phase in Europe. Now, CAVE, right? This is only cross-sectional, retrospective, so perhaps mood-congruent ratings played a role here. And we do not have a representative sample, although subgroup analyses, which we also report in the paper, do not indicate big differences between major social demographic categories. Now, with a bit of delay, we then managed to also go longitudinal, though in a considerably smaller sample using a smartphone-based survey app this time, and where we now can ask really what predicts good outcomes longitudinally, prospectively. So at each of these weekly follow-ups here, we ask participants again about their mental problems in the past week now and about their stresses in that week so that we could calculate these resilience scores, which express under or in the less favorable case, overreactivity to stressor exposure at each of these 5 follow-up time points. Now, this hypothetical guy here would be a consistent overreactor. And you can imagine if they continue that way for a long time, this will mean they accumulate mental health problems and might have a very poor long-term outcome. Conversely, this guy here, consistent underreactor, should do comparatively well over the long run, right? So here I've inversed the scores already to signify better outcomes at the top in positive scores. We also sometimes see changes in reactivity, people like improving or perhaps worsening. But the bottom line here is that levels of resilience across the 5 weeks are predicted by baseline, again, social support, optimism, self-efficacy, and by the self-perceived good stress recovery, as well as negatively by neuroticism. So all this parallels the cross-sectional study I've presented before. And I think that is already great because it suggests that what we've been shouting out during the first lockdown in our quick and dirty cross-sectional approach might have been not too far away from the truth, I think. And now look also at what we see with our kind of cherished construct, positive appraisal style. We can predict either all 5 follow-up time points well and significantly with positive appraisal style measured as baseline. We can also predict sliding windows of average or averages of 3 of these time points, the first 3, then the next round and the next round in the sliding window approach. So it's a pretty temporally stable prediction by positive appraisal style, and that again reconfirms the results from the cross-sectional study. I think we should keep advising people in that direction and do what we can to facilitate and promote these resilience factors, and perhaps in particular positive appraisal habits. But well, 5 weeks, that's still a very short time window. If what you're really interested in are long-term mental health outcomes, and specifically during this current crisis, I think, which is so much longer than many of us, at least in Europe, had hoped after the first lockdown was over this spring, right? Therefore, we are, of course, looking at our long-term longitudinal studies that are going on anyway. We, of course, inserted corona-specific stressor assessments there. We there can also look at biological, behavioral, neural factors, which is a great advantage for prediction, I think. But we can do so repeatedly. That is, we do not just have one baseline characterization, but repeated measurements of potential resilience factors, which will allow us to look at adaptation or resilience processes. But for that, we need a bit more patience. I hope to be able to tell you more in the future about that, maybe at the next of these meetings. And I end my talk by just giving you that very preliminary summary and by thanking you for your attention. It is my great pleasure now to introduce Ran Barzilai, who is the organizer of that meeting. Thank you again, Ran, for doing that. Ran is an assistant professor of psychiatry at the University of Pennsylvania. He's a child psychiatrist working at the Lifespan Brain Institute at the Children's Hospital in Pennsylvania. And yeah, I'm very much looking forward to his presentation.
Hi, everyone, and thank you, Professor Kalish, for this introduction. I am going to expand upon the data that was just presented to us, that present findings from a study that was done in parallel right at the onset of the first lockdown, but the main difference is that most of the population we studied were from the US, not from Europe. But it was a similar approach, and I'm going to try and focus on our longitudinal findings of how we can learn about the risk and protective resilient factors during the COVID-19 pandemic. Let's start. This is my disclosure. I serve on the board of a startup company. It has nothing to do with the data I represent to you now. So I'd like to thank Professor Kalish again for his great presentation before. That saves me a lot of time to give basic definitions of resilience, but I just want to highlight that we define resilience by as an outcome which represent a positive adaptation to a negative event like an isolated trauma or a chronic trauma. So if you end up following the adversity with low psychopathology, we term it a resilient outcome. And it's important to distinguish between resilient outcome and resilient factors. Now, these factors are various measures that are associated with a resilience outcome. And there's an interesting review in Lancet Psychiatry from 2020 showing that resilient factors can come from multiple levels of analysis and multiple domains, from the biological, psychological level to the environmental levels. And there's a table here from 2 leading researchers in the field that really show how diverse are resilience factors. So they can come from, for example, your relationships. They can come from your intra-psychic emotion regulation, self-regulation, self-efficacy, but they can also come from your place in society around you and the level of cohesion in your society and maybe even neighborhood. So we in the Lifespan Brain Institute have been trying to study resilience factors as these multidimensional, multidimensional constructs in the Lifespan Brain Institute under the leadership of Professor Raquel Gur, who will present later. And we developed a tool with the amazing effort from my lead statistician and psychometrician, Dr. Tyler Moore, that allows us to probe for resilience factors that can be broken down to 7 different factors, and they can be divided to 2 intrapersonal factors that tap into self-reliance, self-efficacy, and emotion regulation, interpersonal factors that rely to negative and positive aspects in your close relationship. Positive is trust, confidence, negative is hostility. But it also provides 3 factors of the environment, the neighborhood environment and how you perceive your neighborhood environment, and also life events and peer relationship and victimization. This tool was published in February 2020. And then COVID came along. So as difficult as it is, and it has been over the last year now, for researchers of resilience, COVID-19 presents a very unique opportunity to study what makes some people resilient and others susceptible. So inspired by Professor Kalish's work on how to study resilience longitudinally and how to parse what makes some people resilient and others susceptible, we sought out very early in the pandemic to collect data on resilience factors that can help us predict long-term who is a person that will be a green person here in the graph, meaning have good mental health following the pandemic, and who will be the one that is, let's say, red with negative mental health or bad mental health during the pandemic, and how can we learn at baseline what can help us better predict who will belong in the resilient outcome versus the non-resilient risk outcome. So to that aim, we launched a crowdsourcing website because this was practically the only thing we could do at the lockdown. And we launched it in April 6, again, very parallel to the time that Professor Kalish and his team collected the data. We collected data till today on more than 7,000 participants. I invite you to give it a try. The website is still active and collects data. Unfortunately, resilient during COVID is still relevant today. The domain is covid19resilience.org. And we used a snowball recruitment, which is basically mouth to ear. People shared the link to the website through the social network, which taps to the major limitation of the finding regarding its generalizability. And after people consented to participate in the study, we collected data on demographics. We collected data on COVID-19 related stress, again, that it allows us to control for levels of stress when we talk about resilience. And we collected data on resilience factors using the tool that I described to you previously in the presentation. And lastly, we collected some data on anxiety, depression, and sleep using common questionnaires. The unique thing about our study is that we actually gave people personalized feedback based on their responses, which was a major incentive to people to finish the survey, be honest in their answers, and we actually got some nice feedback from people who enjoyed the feedback they received. And because we sought to make this a longitudinal study for the exact reason Professor Kalish described before, when we study resilience, we asked for permission to recontact individuals. Our cross-sectional findings were published also in Translational Psychiatry a couple of months ago, and our main finding was regarding the levels of stress that people reported during April, and this is from a cohort of more than 3,000 people. And the major finding was that people were more stressed or worried about others than about themselves. And you can see here that people were worried about their family getting COVID. They were worried about unintentionally infecting others with COVID more than they were worried about or stressed about getting COVID. So this is the major finding. Another very interesting finding that we found already in April is that people were already back in April as stressed about the financial burden of the pandemic than of actually catching the virus. So you can say that now, a year into the pandemic, it makes a lot of sense, but finding this as early as April 2020 was very interesting for us. Now, what about our resilience tool? So what we like to see is that basically the participants who scored higher on the resilience factors, and this is a summary score of the questionnaire, had lower levels of anxiety and depression with substantial effect sizes. So for every one standard deviation increase in your resilience factors, you had about 60 to 70% decrease in your level of depression and of anxiety. So our next aim was to see whether we can try and learn about if resilience factors that were collected at baseline early on in the pandemic can really help us predict and tell something about a person's trajectory of resilience or of anxiety during the pandemic, going into the pandemic. To that aim, we teamed up with Anthony Mancini from Pace University, who has been an expert in studying trajectories of resilience in response to trauma. And this effort was led by our lab manager, Grace Domenico, who did all the data collection effort. And statistical analysis was done in close collaboration with Becky Waller, Professor Becky Waller from Penn Psychology, and an amazing grad student, Sam Perlstein. What did we find? We found that basically the trajectories of resilience or risk to anxiety were very similar to what was reported in the literature pre-pandemic. So it means that most people in our cohort, about 3 in 4, were actually low in reporting anxiety in the 3 time points that we collected data in April 2020, May 2020, and August 2020. We collected longitudinal data from around 1,300 people. So the sample size is not too small, but most of them reported low levels in anxiety throughout. These are the resilient people, and this is in line with the literature. However, about 10% or more than 10% of the population were chronically stressed and anxious. These are the participants who are the most stress susceptible. And interestingly, we saw another 2 trajectories that were also reported before in the literature. One is the recovery resilient group, which is just about 7.5%. People who start up very stressed or anxious, and then as the pandemic progresses, they become, they adapt and they are not anxious anymore. And another interesting group is the group that starts off as low anxiety, but then develops anxiety going into the pandemic. So if you think of these 4 trajectories, by the way, I didn't go into the statistics, they were all derived using an LGMM model. This can be clinically significant because when we begin the pandemic, and now if we can extrapolate to another traumatic event or major stressor. So in the face of a major stressor, people basically can be divided into 2 types of people. The ones who are very anxious, here, red and green, and the ones that are not, here, orange and blue. But as a clinician, I want to know who are the people who are not anxious that I should be worried about, meaning who are the people who are likely to adapt, which is the majority, the blue people here, and who are the people who are likely to become anxious over time, the orange here. And if I can differentiate between these 2 groups early on, I can allocate intervention on a personalized level. And if we look at the mirror of that, the high anxiety group at the beginning, I want to know who are the people that will just be okay, even if I am not intervening with them, the green people who will adapt, and who are the people that will remain chronically anxious. So to that aim, we went back to the data we collected at baseline. And I remind you that we collected data on 5 resilient factors that were collected in April 2020. And what we did is we compared these baseline resilience factors across the 4 trajectories, trying to tease apart what makes the resilient people different from the other groups. And you can see that they differed basically on all of the resilience factors, which again, somewhat validates the relevance of the resilience factors we probed for. Specifically, I want to highlight 2 comparisons that I think are very relevant to the clinical challenge I talked about in the previous slide. The first factor was emotion regulation that had the highest or the greatest effect size in differentiating between the resilient and the non-resilient groups. And you see how your chance of being resilient drops as you score lower in the emotion regulation. Just to give you a sense, the question we asked were very straightforward about how a person can stay focused in times of stress, how they know that they will not become depressed in times of stress, and questions like that. And look that you can see the difference significantly in emotion regulation between the blue resilient people and the orange delayed anxious people just by comparing the baseline emotion regulation. So we can say that we hope that this tool, if it is used prospectively, can help us identify people who are more at risk to become anxious, even though they do not present anxious at the beginning. And the other comparison I'd like to highlight is the comparison that was significant between the red group and the green group. So I remind you, these two groups were anxious at the beginning, but then the trajectories separated. The red remained anxious and the green became non-anxious. So if you look at the significant difference among the resilience factor, the only one that was statistically significant in comparing the two was the neighborhood environment. So now if we go into interpretation of this, one might say, well, maybe something in the environment of a person can present an opportunity for them to adapt over time that people who don't feel safe in their environment do not have. And this is why the green people become less anxious over time. So this analysis gives you an illustration of the utility of prospectively studying and collecting resilience factors and then retrospectively seeing how they contribute to resilient outcomes of the pandemic. Briefly, our take-home message. So we have shown that COVID-19 is a unique opportunity to study resilience globally using an online research crowdsourcing website that can actually make some clinical relevant data. Emotion regulation appears to be a strong and potentially probably modifiable resilience factor. And of course, we need to do more and more longitudinal studies that can help reveal predictors of resilience. The limitation that is also relevant and presented by Professor Kalish is that this is a convenience sample and it was oversampled for academic, white women. But still, the longitudinal data, I think, somewhat mitigates because we judge every participant compared to himself or herself at baseline, but we definitely need to replicate in more diverse sample. Lastly, I'd like to thank all the team that contributed. This was a massive team effort done under the leadership of Raquel and Ruben Gur at the Lifetime Brain Institute. And again, the collaborators that I'm truly thankful and all the participants who took the survey. These are my funding agencies and I thank you for being with us. And after presenting data on the population level of resilience during COVID, I'd like now to present the next speaker, who is Professor Doron Gotthelf from the Sheba Medical Center in Tel Aviv University in Israel, who is a great collaborator, and he will tell us about resilience amongst healthcare providers and amongst COVID patients. Very looking forward to hear your talk, Professor Gotthelf. Looking forward to that. Thank you.
Thank you, Ran, for pulling the session together and for the nice presentation. As you said, the topic of my talk are two populations. And the first is healthcare workers, and the second is isolated hospitalized COVID-19 patients. So the studies I'm going to present are in the same vein of the previous presentations, which means the data were collected mainly during the first wave of COVID-19. So we have the first sample, the Israeli physicians we collected at the beginning of the first wave of COVID-19 in Israel. And then the study of healthcare worker at my hospital at Sheba Medical Center. The data were collected at the end of the first wave in Israel. And then the hospitalized patients, the data, the 3 time points of the hospitalized patients were in between the beginning of the first wave and continued into the in between the first and the second waves. So we published several papers, and I'm going to, here are the collaborators. So you can see that we have already 5 papers that were published and 2 under revision. And this is the work of many people. Among them is RAN, another study that we are not going to present here was Israeli-US collaboration. And I'm going to run into the first paper, which is anxiety and pandemic-related stress and resilience among physicians during the COVID-19 pandemic. So we distributed a questionnaire through the Israeli email list, which include 30,000 physicians that are on this list in Israel. I want to emphasize these are all the physicians in Israel, not only those that treated COVID-19 patients. And we received from these 30,000 emails, we received more than 1,000 responses. There were about half and half males and females, and they varied by age from as young as 25 to 88. They came from all professions of medicine, as you can see here. And the tools we used are the 8-item version of the PROMISE anxiety module. And we also collected items that were studied in previous pandemics. And by collecting them, we called it the pandemic-related stress factors. And we also used the Connor-Davidson resilience scale, a scale that consists of 10 items. We saw that only 15% of the physicians felt protected by the government and hospital. I remind you that this is the first wave of the COVID-19, and there were many complaints about being not protected from the physicians. And 63% reported coming to work because they feel mission-driven, and 27% reported anxiety scores above the cutoff level of the PROMISE. In terms of factors that were associated with the anxiety, low resilience was a risk factor or associated with anxiety in our sample, mental exhaustions, and anxiety about being infected or infecting the family. I must say that similar to Dr. Barzilai's finding, in all of our samples, people reported that they are more anxious about infecting family relatives and then about being infected themselves. Sleep difficulties were associated with anxiety levels, and feeling obligated to work, and lack of knowledge about prevention and protection. The second study was conducted among healthcare workers. Healthcare workers, I mean both physicians and nurses. And it was conducted in our hospital, Sheba Medical Centers. We were the first center to establish COVID-19 teams which means we had an intensive care unit and internal medicine unit that were dedicated to COVID-19 patients. And we could also recruit a control group in our hospital, which was physicians and nurses that were in internal medicine and intensive care unit and other units in the hospital that did not treat COVID-19 patients. So we used the same measure, the PROMIS anxiety, but this time we also used the PROMIS depression module. We took the PTSD 5 items to assess the post-traumatic stress symptoms. We had a question about the self-perceived health. And we also asked the teams to report if they witnessed patient death. What we can see here that those on the COVID-19 team, we had 189 physicians and nurses, and in the non-COVID team, we had 639 physicians and nurses. Those on the COVID-19 teams were younger, were more males. More of them reported being quarantined. More of them were living alone, and more of them were single. In terms of post-traumatic stress symptoms, these were significantly higher among the COVID-19 team compared to controls. But interestingly, the anxiety and depression scores were not significantly different between the two groups. As can be expected, the age of death of patients in the COVID-19 units was on average younger, 71, versus 81 in the non-COVID worlds. In terms of the total number of deaths during the 2 months of March, April, during the first wave, we saw there were total 33 deaths on the COVID-19 wards, and we saw a decrease in death cases March, April 2019 to March, April 2020 in both the internal medicine and other hospital wards. There was a decline in death cases. Now, going to the major finding. So first of all, as I said previously, in the COVID-19 team, there was a twofold increased likelihood compared to the non-COVID-19 teams. So I didn't say that, but they were twice as likely to report that they were witnessing patient death. And the most interesting finding, there was a specific association between witnessing patient death and PTS, post-traumatic symptoms, in the COVID-19 group. So witnessing patient death was a robust risk factors, odds ratio of 4, to report post-traumatic stress symptoms, and it was unique to the COVID-19 healthcare workers, and was not present in the non-COVID-19 team, this association. Now I'm going to run quickly into the other study that we conducted, and this is the mental health symptoms among isolated patients and their relatives. When I say isolated patients, I mean those patients that were hospitalized within the COVID-19 wards that we opened at Sheba at the beginning of the first wave. And I want to emphasize that during this first wave of COVID-19, all patients that were infected, even when they were asymptomatic, were hospitalized. Obviously now during the second and third wave, this was not the case. During the second and third waves, only symptomatic patients with respiratory symptoms were hospitalized. But during the first wave, all patients, all positive cases of COVID-19 were hospitalized. And we did a short longitudinal study in which we approached all hospitalized patients we tried during the first days. It was between day 1st and day 5. And then we reapproached them about a week later, between day 6 and 18. And then a month after hospitalization, all of them by then were discharged and were at home, and it was 30 to 45 days afterwards. And we also approached their first degree relatives that were living with them, and 91 adults and 34 children. And we collected data. We interviewed them using the PROMIS and the PRSF. And we also assessed their comorbidity, medical comorbidity by the Charlson Comorbidity Index. And we also assessed their medical condition based on the presence or absence and severity of respiratory symptoms. 1 month after admission, we also assessed the post-traumatic symptoms of the patients. And what we can see here, that first of all, we can see that at baseline, anxiety symptoms were more prominent than depressive symptoms. We see that both patients and their relatives were similarly high on anxiety symptoms. We can see that adult patients were more anxious than children. Children, we think the reason is the children have only the subjective burden of fear of the pandemic, but they don't have the objective burden of taking care for the home and taking care for financial issues. What were the risk factors that we found, or actually the factors that were associated with anxiety at baseline? These were social disconnectedness for the patients and for the relatives feeling unprotected by the hospital. And an interesting risk factor, women, like we know in the general population, were more anxious than men. And ultra-Orthodox Jews, 1/3 of our sample consisted of ultra-Orthodox hospitalized patients. They were less anxious than the secular patients. And we can say that anxiety protects you against being infected. And we know that we have a problem in Israel that many ultra-Orthodox patients, ultra-Orthodox people, they report that they are not anxious, and maybe therefore they are more commonly infected. We have very high rates of infections among ultra-Orthodox Jews in Israel. I will skip this slide for the sake of time. What were the baseline factors predicting PTSD symptoms 1 month after hospitalization? High initial anxiety, high initial depression, social disconnectedness, mental exhaustion, and long hospitalization. So we think this is an interesting finding. So we think that the fact that all COVID-19 patients, even the asymptomatic, were hospitalized during the first wave had a mental health cost. So we think with the benefit of hindsight, we can say that it was a mistake to hospitalize all positive COVID-19 patients. To conclude, isolated hospitalized COVID-19 patients at risk to develop mental health symptoms are women, those that report that they are lonely, those that had longer hospitalization. It was kind of a nightmare for them being in hospital. You had one test negative, negative, and then another positive, and then you have to wait for another negative test. It was really a nerve-wracking to wait for 2 negative tests to get discharged. And also those with high anxiety and depressive symptoms of admission were more likely to develop post-traumatic symptoms. The interesting group of healthcare workers treating COVID-19 patients, they were at risk for anxiety and depression and post-traumatic symptoms. And witnessing patient deaths was a specific risk factor for post-traumatic symptoms in healthcare workers in COVID-19 units. And I want now, in terms of recommendations for treatment, to rely on the very interesting editorial at the New England Journal of Medicine by Shapiro and colleagues. And what they taught us in this editorial, that healthcare workers tend not to approach individual therapies or support, because if you suggest them by hotline or by personal contact to come to therapy, they are reluctant to do that, because they are educated that to care for myself is selfish. And also we know the mythos that physical and emotional burnout are major components of the profession glorification. Therefore, self-referral programs for individual therapy are failing. On the other hand, as Shapiro emphasized, peer support programs of healthcare workers working with COVID-19 patients are more likely to succeed. And trauma-focused psychological interventions are recommended to work through the trauma associated with the encounters with deaths of patients. We think the reason that witnessing patient death was so traumatic in COVID-19 world was because the patients were younger, and especially during the first wave, the healthcare workers did not have good protocols how to treat the patients, so they felt kind of helpless. And because the families, as was mentioned by Dr. Kalish also, the families were not there to escort the patients, so much was relied on them more than usual to follow the patients to their tragic death. So I thank you. Okay, so it is a great pleasure for me to introduce Professor Raquel Gur. Professor Gur is a friend and colleague. She is a professor of psychiatry at Penn University and the establisher and director of the Lifespan Brain Institute. Raquel, please go ahead.
Thank you, Ran, for the invitation to participate in this timely symposium. I'll be focusing on racial disparity in Philadelphia, and I'm representing the IGNITE group, that is a collaboration between the Lifespan Brain Institute, LIBI, you heard about, and the Maternal Child Research Center in the Department of Obstetrics. After a competition, we termed our working group, collaborative group, IGNITE, Intergenerational Exposome Program, and the program was established before the pandemic. These are the group of people who have persevered in the effort in developing a cohesive line of research. And they're coming across departments, and you know Ran already, and there are pediatricians in the group, neonatologist, and Dr. Elowitz, the obstetrician. And our goal was to evaluate the impact of maternal factors that are part of the exposome on the developing fetus and following them through early years of life. So against this background of plans and sort of getting ready to go, COVID-19 came upon us. And as we have noted among the previous speakers, had major impact, global impact on health and the sense of well-being that is almost palpable. And we have learned to live from acute to becoming more chronic. We know that in the United States, the pandemic disproportionately affects Black and other disadvantaged communities. I'm going to focus on Black women. So this is noted in the number of individuals affected, morbidity and mortality among Black people, young and older people across the United States. So it is, we've been called, health professionals have been called upon to pay attention to health disparity that during a time of crisis, it even grows more significantly. Pregnant women overall are at the highest risk for depression and anxiety following adversity. There's a growing literature on it that is pre-COVID, let alone when you add to the vulnerability of pregnant women and of disadvantaged communities, such as Black women, there is marked racial disparity in pregnancy outcome in non-pandemic time and more so in pandemic times. So with this background in mind, we thought that we are prepared to move forward. COVID is upon us, and we have developed, as Ran has nicely described, the assessment online of risk and resilience factors. Now we have added more information that relates to pregnancy-specific challenges, in addition to the common challenges that are related to COVID-19. So the goals of the study were to evaluate the impact of the pandemic at the height of the stay-home lockdown. So this was in early April, in a diverse sample of pregnant women, but ensure that Black women are represented, to look at race differences in pandemic-related experiences and worries, general and pregnancy, to assess anxiety and depression, as nicely presented in the previous, that are the common psychiatric manifestations in adversity, and look what resilience factors might mitigate the pandemic burden. So this is a busy slide, but I will highlight the approach. So during the height of the lockdown, so we started April 17, 2020, with 2 weeks, and we stopped data collection for this purpose on May 1st. Okay, so there were over 3,500 women who were presented as pregnant to the Department of Obstetrics and Gynecology pregnancy program. And questionnaires were online sent to all of them, and it was completed through email. They were contacted repeatedly, and after 3 contacts, repeated contact, we stopped. Some of the women, we ended up with a sample of 913 women. We know a lot of information about all factors that relate to the background, insurance type, medical problems, etc., because we have access with their permission to the electronic medical records. And we screened out women that were not really pregnant or had early pregnancy, did not complete pregnancy, and included only those that we can follow up later on. So who ended up among the 913 pregnant women? Notably, they were all adults, older than 18. The mean age was 32, with Black women 29, a little bit significantly statistically younger. Gestational age, we had the representation from all phases, from the first trimester, second and third trimester. 62% were white, including as white, non-Latino. 23% were Black, and we focused on the Black compared to the white, and for this analysis did not include Asian or other. 76% of them, a large part of the population, were married and living with married or living with a partner, less among the Black women, and for over 55%, it was the first pregnancy. So the Black compared to the non-Latino white women were a few years younger, as I noted, mean age 29. Their lower socioeconomic status, and we have measures that relate to income and environment where they grow up. So they grew up or were living in a lower socioeconomic group. They were more single, without a partner or married, and it was not more of them had another child. So parity was more than 0. These measures were included in the statistics of all an analysis covaried. So what were the procedures that were administered? There were online data were captured by a RedCap based survey. It was brief and validated measures that were adapted for COVID-19 from what Ran described before. COVID-19 exposure were 5 questions, worried were 6 general questions, and 4 specific to pregnancy, of what can be the impact of COVID-19 on the pregnancy, such as getting prenatal care. I will illustrate it in a minute, going to a smooth delivery, and being able to meet the needs of a newborn. We measured anxiety with the GAD-7 and depression with the PHQ-2. Resilience, an important factor that has been highlighted by the previous speakers, with the 21-item questionnaire that included self-reliance, emotion regulation, supportive close relationship, non-hostile close relationship, and the perceived neighborhood safety. What were the results we obtained? And I will, after that, first highlight the results and then show the graphs. We found that Black pregnant women reported greater likelihood of suffering through the pandemic from being affected, their employment being affected negatively by the pandemic. So either losing the job or cut in the hours of the job. They were more concerned about the lasting economic burden of the pandemic, and they're more worried or worries related to prenatal care, birth experience, and postnatal needs. So significantly more than white, non-Latino white women on general related pandemic exposure impact and on pregnancy specific. They were more likely to meet criteria for depression when we use a more stringent criteria. It was not significant with all the covariates, but when we use a more less stringent, that has been done in other studies in the literature on depression, they were more depressed. Resilience factors, they differed in specific factors. Self-reliance, they were significantly more self-reliant and more regulating their emotion, the Black women compared to non-Latino white women. And now here's the data as you can see it. So if we look at the psychological burden, the worries that relate to the pandemic by race, what you can see on the top are general pandemic related worries. Starred are significant, and these are listed: the family getting COVID, self getting COVID, unknowingly infecting others, financial burden due to COVID, dying from COVID, and currently having COVID. And you can see that the Black women in gray have they have less concern about family getting COVID, less unknowingly infecting others, and more on the financial burden, concomitant with lower socioeconomic level of functioning, the greater concern about the financial burden. If we now look at pregnancy-specific pandemic-related worries that include having good birthing experience during the pandemic, Black women are more concerned about that. Receiving good prenatal care during the pandemic, Black women are more concerned about that. They are not more concerned about getting exposed to the virus that causes it during prenatal visit. So prenatal visits are similar between white and Black women, but they are more concerned than white women about access to food. Food's insecurity is common. Medication, the baby care needs during the pandemic. So you can see that in key pregnancy-related domains, Black women are more, report greater level of worries than white women. And the question is, what is the impact of that on the developing child? The rate of anxiety, as I said before, measured by the GAD, no differences between the two. And here, when there's a more stringent cutoff point, and we take covering into account, they are not more depressed, but with a more, I'll call it, I'm not sure it's liberal, but if we take 3 rather than the 2, is that we see that it's they are more, report more symptoms of depression. What are the difference in the resilience during the pandemic? So resilience, these are the factors from self-reliance, emotion regulation, supportive close relationship, non-hostile close relationship, and neighborhood safety. There are 2 domains, as I noted when putting up the overall the results before. Self-reliance is higher in Black women, and emotion regulation. And as we heard before, emotion regulation is important as a potential coping or mediator of the impact of COVID-19 or other adversities on well-being. So I will summarize what we found and put it in the context of what we are doing now, because this is an area that little is known about. So we see racial disparities that related to COVID are present in pregnant women. So COVID is an additional factor, major factors to racial disparities in health. As you know, in the United States, there's more morbidity, not related to COVID, among Black women, more preterm birth, and higher level of complications. And this is regardless of socioeconomic status. It can happen even to those with equivalent socioeconomic status. Are Blacks taken less seriously? This is something that we need to pay attention to. The Black women have general and pregnancy-specific worries, and some higher resilience factors that are important to address and utilize, capitalize on the resilience. And the COVID-19 is likely to have a higher burden on Black women, and it provides a critical window for intervention for the mother and the offspring, for the dyads. So we have now evaluated, we have some data, but for the sake of sticking to our schedule, I'm not going to present, but we have data, we've been evaluating the women. All of them have now delivered. The last delivery was last week. So we are evaluating the women in waves during the pregnancy, post-delivery, and plan to see virtually the infants and follow them with a program of early childhood in the Department of Psychiatry at CHOP and in pediatrics, follow them through the first 5 years of life, and document neurodevelopment in the infants. Notably also in many of the studies that we do, we have biological samples available on the mother and the child, and we'll be able to have a rich data set with a focus on those who are disadvantaged. There's a special term for it that it puts together the COVID and the systemic racial disparity. So it's with a unique opportunity to evaluate it. Thank you very much.
Thank you, Raquel, for this very interesting talk on a very important population. And it will be very interesting to follow up on the children who are the COVID pandemic children and try to understand how this major global stressor affected their development over time. I'd like to thank everyone who participated in this symposium, who gave us really nice lifespan perspective on resilience during COVID. And we hope that we can see you again next year, hopefully with the pandemic behind us, but still with a lot of interesting findings and data on how we can better understand what makes people resilient during times of stress. And maybe most importantly, how can we leverage this knowledge to develop specific interventions that can foster resilience and mitigate the cause of stress for people. Thank you again.